So we start our second session. So our next speaker is Dr. Imran is not here, unfortunately, he has some emergency in hospital. So he's gone there. So we move to the second speaker, Dr. Fayaz Ahmed. He's a consultant cardiothoracic surgeon, King Fahad University Hospital, Al-Khobar, and he's going to present proposed myocardial infarction, ventricular septal rupture.
ये कैमरे में आना शुरू Assalamu alaikum everybody. The post-MI VSTs, even though are rare, I just chose this topic because we recently had a case and I thought it would be a good revision for us all to just go through this rare complication. VST complicates about 1 to 2% of acute MIs. The first successful correction was done by Cooley in 1957. So this is a complication which the cardiac surgeons have been dealing with for a long time. The mortality, despite various improvements in therapy, still remains very high. The 30-day mortality, even in the present STS data, is about 74%, and 1-year mortality is 78%. The relative improvement in survival and declining incidence is due to the present early diagnosis of the acute MIs and early flow restorations like primary PCIs and more aggressive surgical intervention in terms of the surgical techniques, mini-invasive techniques, and the different armamentarium presently available. And also the aggressive BP control in the post-MI situation. Still, the predictors of VSD, post-MI VSD remain advanced age, anterior location of the infarction, female gender, and no history of smoking. People with no history of smoking who come with acute MIs, mostly due to acute spasms, tend to have post-MI VSDs. And also thrombolytic therapy after 12 hours is also suggested to be a like a predisposing factor for post-MI VSDs. In terms of coronary anatomy, the patients prone to have VSDs are associated with 100% occlusion of the culprit arteries. The average time to rupture, it can vary between 2 to 4 days. Our patient ruptured 2 days after his presentation in the ER. Time course may be accelerated by thrombolysis, possibly related to intramyocardial hemorrhages. The principles of management remain after load reduction, vasodilators, diuretics, balloon if indicated if patient is unstable, and other mechanical support either with an ECMO or a tandem heart. Surgical repair remains the definitive treatment. Medical management alone has up to 94%, almost like 100% mortality if not intervened. The STS national database consists of 2,876 post-MI VSDs, wherein the 30-day mortality after operation is 42.9%. This is one of the highest mortality rate for all types of cardiac surgeries. There's a sharp decrease in mortality with a delay in repair. It could be due to a selection and survivor bias. So the general trend is to wait for the surgery because that gives some time for some stability of the frail infarcted myocardium. So the mortality at 7 days is about 54%, and Repair after 7 days is 18.4%. Now, the other thing which we also have is a transcatheter septal approach. Patient had that. It could be in patients who are stable but inoperable due to the anatomy. If it is a posterior VSD or multiple VSDs, this is an option which can be considered. The procedure success is about 89%, but however, still the 30-day mortality remains very high, up to 38%. Higher mortality, as with surgical intervention, remains high if it is earlier intervened. Complications of device closures also include arrhythmias, device embolization, ventricular rupture, and residual shunt. The anatomy of VSDs, post-MI VSDs, they can be classified as simple and complex. Simple is a through and through defect between the ventricles. It is usually seen in the anterior type of VSDs. It could be complex, wherein a dissection track can be formed, leading to septal defects. These are mostly seen in the posterior VSDs, which are again very difficult to repair. Enteroapical septal rupture, these form the major chunk of the post-MI VSDs, about 80% of the cases, and usually the LAD is the culprit. Posterior septal rupture, as expected, is due to a dominant RCA with extensive RV infarction, or a dominant left circumflex. Mostly the RV is spared in these cases. Multiple defects also could be formed, which are about 5 to 11% of the post-MI VSDs. Secondary to infarct extension, wherein a VSD is formed and the infarction continues to extend and more VSDs are formed. This could evolve over a period of days. The pathophysiology, anteroseptal rupture could lead to tamponade, or it could lead to RV failure due to volume overload in an unstable patient. The posterior VSD is complicated by usually severe mitral regurgitation. And there is also shunt reversal due to elevated RV and diastolic pressure as the volume overload continues. Diagnosis, clinically, there is a loud, harsh holosystolic murmur within the first week post-MI, best heard in the left lower sternal border, less loud at the apex, which differentiates an MR from a VSD, associated with a palpable thrill. Depending on the location, may radiate to the axilla, mimicking the classic mitral regurgitant murmur. Up to 50% of these patients experience chest pain. The other 50% may not have chest pain. Congestive heart failure and shock are the other presenting features. Diagnosis, echo is almost 100% sensitive to pick up the post-MI VSDs. The need for catheterization, 2/3 of the patients have multivessel coronary disease. There is a decreased operative mortality and improved late survival in patients with multivessel disease, meaning that if this has been a chronic ongoing problem, patients tend to be more stable. So their operative outcomes are better. Cardiogenic shock is not a deterrent to cath. These patients should be taken to cath immediately, even if they are unstable. Theory of management, hemodynamic stabilization so as to minimize the peripheral organ malperfusion, reduce systemic vascular resistance, maintain or improve coronary flow. If there are any vessels to be opened, they can be opened. Maintain cardiac output if necessary by a balloon or an ECMO. The timing of surgery, surgery should be performed soon after diagnosis in most patients if they tend to remain stable. Patients in cardiogenic shock should be operated on immediately after angiogram. Hemodynamic stable patients should have surgery on an urgent basis, not like emergent, but as soon as found fit, once the antiplatelets are washed off or if patient is can sustain for as long as possible. This slide is a bit congested, but what it basically shows is that if you tend to weigh the mortality, the operative mortality can come down to up to 10%. But then again, this could be a bias because these patients tend to be stable and the surgery is converted into an elective procedure, so the operative mortality can be low. This is something which is debated and can be taken up on a case-to-case basis. The operative techniques, the classical approach for an anteroseptal rupture is basically to remove the infarcted segment and reconstruct the ventricular septum using Dacron patches. This is the classical approach wherein the infarcted segment is removed and the free wall is reconstructed with a Dacron patch. And closure also can be double-breasted and buttressed with a Dacron strip. Outcome, the predictors of early mortality, as mentioned earlier, advanced stage, inferior location of the MI with multiple VSDs, diabetes mellitus, elevated RA pressure, pre-op, and absence of an intra-aortic balloon pump intra-op. So most patients will be benefited with an intra-op balloon. In patients with cardiogenic shock, mortality reported to be the highest. Posterior VSD is another factor strongly associated with poor surgical outcome due to the difficulty of exposure and frequent concomitant infarction of the posteromedial papillary muscle, which tends to lead to severe mitral regurgitation. The mitral regurg is also very difficult to address because the modeling of the LV is disturbed, wherein it becomes very difficult to control the MR. Replacing the mitral valve will add to the length of the procedure and make the procedure more morbid. The exclusion technique is the one with most with the best outcomes. The LV is excluded from the infarcted muscle using bovine pericardial patch. This maintains the modeling of the shape of the LV. No infarctectomy is performed. RV is undisturbed, so the outcomes are better in the exclusion technique. Post-op, many patients tend to be on dialysis because of the pre-op status, prolonged ventilatory support, and residual and recurrent VSDs are common in some patients. Some may require reoperation to address the residual VSDs if they're unstable. So the take-home message is post-infarct VSD is a rare but lethal complication of MI. Surgical repair is definitive treatment. Delaying surgical repair may be beneficial if patient can be stabilized. Principles of successful VSR repair remain the double patch technique with infarct exclusion. Thank you.